Okay, we're going to launch into renal diseases. So as a review, the area of the kidneys which contain the glomeruli is, or the areas are, medulla, cortex, capsule, pyramids, or columns. Cortex, very good. This is all review. Just putting it into kind of a test question. So we're going to look at the following categories of diseases. We're going to look at glomerular diseases, renal failure, as well as infections. So the functional unit and the basic structural unit of the kidney is known as the nephron. And the filtration unit of the kidney, if you recall, is the glomerulus and the Bowman's capsule, and that actually forms the renal corpuscle. So I just want to orient you all on where we are in the body, have you kind of focus in on, this outer capsule, looking at the cortex, which is the outermost region, and then obviously on the inside is the medulla. And these medullas are organized into these pyramids. The pyramids kind of dump into these minor and major calyces, and then you have the renal pelvis, and then it filters into the ureter down to the bladder. Then from the bladder out the urethra into the external environment. Okay, so as we review, we talk about the units that function within the kidney. We talk about the nephron and the glomerulus. So the glomerulus is this basic filtration unit, and the nephron is the basic structural and functional unit. And so that's what you could write down on this particular slide, and maybe just draw kind of urine flow from the kidney through the ureter to the bladder and out the urethra. And that sort of organizational flow that you'll see later is going to be helpful when we talk about infections. So we're going to talk about urinary tract infections, and where they can be found, where they originate, where they go, where they migrate, why they can be a problem. Okay?
Can you repeat that, the first part? You said that
Which
the
part?
nephron is the functional unit. What's the second thing?
The nephron is the basic structural and functional unit of the kidney.
And there's another point you mentioned before.
The filtration unit?
Yes.
Yeah, so the filtration unit is the glomerulus and the surrounding Bowman's capsule. Okay, and remember, all of this stuff is recorded and online. Okay, so if you miss something in your notes, you can just play it back and pause it, replay it 75 times if you like. Okay. All right, so also review from 202, right? Just another picture. Just to appreciate that there is a vascular supply that actually follows all of the renal tubule structure and architecture. And so we have inflow as well as outflow. A third of the cardiac output comes right off the aorta, goes into the kidneys. It's divided almost equally. It's about 55-45. So one kidney tends to get a little bit more blood flow than the other, just the way that they're situated. And the whole purpose of getting that much blood flow right off the bat isn't necessarily to perfuse the kidney as much as it is to actually filter your blood. You with me? So the metabolic demand of the kidney is not a third of cardiac output. It's just that it's important to filter your blood of metabolites and then excrete it out the ureter to the bladder and then to the urethra. Okay, so some terms that I want you guys to be familiar with. Urea. Urea is the catabolism of amino acids. That's what's in urea. Uric acid is the catabolism of nucleic acids. And then creatine is the catabolism of creatine or creatine phosphate, a metabolic waste product. So urea, catabolism of amino acids, and these other terms that might be found within your reading are uric acid, the catabolism of nucleic acids, and creatine, which is the catabolism of creatine or creatine phosphate. Azotemia, this is an elevation of blood urea nitrogen, or what's called BUN, B-U-N, shown at the bottom of the slide. Blood urea nitrogen, azotemia. So this is a measure, BUN is a measure of urea in the blood, and it gives you an indication of how the kidney is functioning. So if BUN levels are high in the blood, that means the kidney function is actually low, or something might be wrong. Question? You have a question or no? Okay. Uremia. This is a term that loosely describes kidney failure. Uremia. Proteinuria, what do you think that means? Protein in the urine. Hematuria, specifically red blood cells in the urine, because pyuria is the presence of white blood cells in the urine. And oliguria, this is what? Low urine production. Oliguria. Low urine production. Okay, so this might help you with some of the reading, some of the quiz questions that come like on Friday, or maybe some of the ones that you already experienced today. So the BUN levels or urea levels in the bloodstream that are high usually means that protein metabolism is running high. And if it remains elevated or continues to escalate, it gives you concern that maybe the kidneys are not functioning correctly. So that might be something that we measure in patients that are on like a South Beach diet, right? Or a ketone diet, or one of these fad diets where you're trying to trick the body into burning more protein and fat rather than sugars. But now the question is, do we need to measure these patients' blood levels of urea to make sure that they're not poisoning their system with their diet? Okay? And the answer to that question is yes, we should be, because a lot of patients don't do it in a healthy way. They do it too quickly. Okay, so let's talk about renal diseases, specifically with the glomerulus. Now, what's the glomerulus?
Filtration unit.
Filtration unit. Basic filtration unit. Okay, so this is where everything happens. This is kind of the purpose of the kidney, is the glomerulus in a way. If you had to boil it down to one particular architectural structure, this is the one that makes the most impact to the functionality of the kidney. That's the glomerulus. So disorders that can alter or impact glomerular function are things that will alter glomerular filtration rate. You guys remember GFR, glomerular filtration rate, from 202? So glomerular filtration rate is basically the rate at which you make urine, right? GFR is the rate at which you filter the blood, and on the output you actually collect filtrate, which later becomes urine as you concentrate it. Many of these diseases are immunological in problem or in nature. So some examples that we're going to talk about, there's three. Glomerular nephritis, diabetic nephropathy, right? And that involves an accumulation of extracellular matrix in the glomerular basement membrane. And we just talked about this, right, with type 2 diabetics. We just showed that thickening because of the advanced glycosylated end products. So the kidney disease that these type 2 diabetics can realize is this diabetic nephropathy, where that basement membrane of the glomerulus gets thicker. What do you think that does to GFR? Do you think it facilitates filtration with a thicker membrane, or do you think it impedes or prevents it from happening? It impedes it and prevents it from happening. So the patients have oliguria, low urine production. They have high urea or BUN in their bloodstream, right? Because they can't filter out the blood because they have these thickened membranes from too much sugar that's causing that thickened basement membrane with the advanced glycosylated end products. Does this all make sense? See how this is all fit together here? We just use like $20, $50 terms all in one, 2 sentences, one paragraph. Okay, it's kind of cool. It's kind of fun how they all merge together. So I'll say it again just so you can kind of catch this, okay? So we just talked about a type 2 diabetic that's unmanaged. And we said they have diabetic nephropathy. And when we looked back at their disease state, we looked at histology that showed a thickened basement membrane. Do you remember the thicker pink ribbon versus the thinner basement membrane that I pointed out on the slide? So that thicker basement membrane is because you have too much extracellular matrix from the glycosylated end products, too much ECM in the glomerular basement membrane, that's the GBM. And that led to that thicker pink ribbon. So when the blood flow comes across that basement membrane, it's not going to filter as easily because you have a thicker membrane that has to go across. And so you decrease your urine production. Not as much filtrate. GFR goes down. If you decrease your urine production, the patient is oliguria, right? Low urine production. If you're not filtering that blood and it's a type 2 diabetic that's unmanaged, they're not getting their energy from sugar metabolism. They're probably getting their energy from protein metabolism. So what happens to their urea content in their bloodstream? Goes up. Bun levels will be high. This all makes sense? So if you do a CBC, if you do a blood screen, and you look at urea or bun levels, they'll be elevated in the patient with type 2 diabetes. So I'm just trying to talk through the entire flow of what we just came from to where we are today, right now on renal, and show you just one clinical example of diabetic nephropathy. Okay, so the third one is going to be nephrosclerosis. So the diabetic nephropathy, you probably get now because we just came out of that lecture. These two we're going to have to characterize because these are two new, all three of these are big words, I get it. These two, the glomerulitis and the nephrosclerosis, we're going to have to talk about. Okay? So let's tackle glomerulonephritis. Glomerulonephritis is an inflammation of the glomerulus. That sounds bad. It is bad. Do you remember in the beginning of the semester I said that most every disease that we're going to look at this semester is going to involve some component of inflammation. So we're still holding true to that today. And next week, when we finish up with cardiovascular, we'll see that again be the case. The pathogenesis is immunological because you have antibody production. You've got antibody production that's being triggered because of the inflammatory event. And so now you have a circulating antibody that's an antibody-antigen complex, and it's going to get lodged somewhere. When we talked about this antibody-antigen complex circulating, we talked about that in what lecture? You guys remember? Hypersensitivity. Thank you. Very good. So, which type is it? Type 1, 2, 3, or 4? It's type 3. Very good. Okay? See, be careful, but you just learned something and remembered it, right? So, like, if I asked that question on the exam, I'd be super happy, and that's why I anticipate your scores are going to continue to increase, because you're remembering this stuff. It's not just going in one ear and went out the other, but it actually makes me super happy. Like, that's why I'm here. So I really am excited about that. Like, this is a type 3 hypersensitivity. So we got an antibody-antigen complex, and we talked about hypersensitivities of type 3 nature. Find places where blood flow can circulate that complex. Does it make sense that we're talking about the kidney now? We also talked about it being in the vasculature, vasculitis, and we talked about it being in the joints. All those are places where blood flow is. So now we've got this circulating antibody-antigen complex, and we're gonna talk about this in a couple of slides. And then we have a second type, which is also known as an in situ, an anti-GBM antibody, an anti-glomerular basement membrane. So this would be a hypersensitivity that's not type 3, it's type what? It's type 2. It's not a circulating complex, it's the antibody binds to the basement membrane. You with me? So that's a type 2 hypersensitivity. So, if we look at these pictures at the bottom, which might be harder to see on the screen, but maybe easier in your notes, we've got our in situ, which is our anti-GBM, anti-glomerular basement membrane antibody. So we have an in situ, that's this one, where you've got the antibody binding to an antigen on the basement membrane. So you see how this is evenly dispersed across this red line. You guys see that? This is another example of in situ that is, again, some glomerular antigen, but it has the exact same result. Okay? I'm really going to test you on this one and not worry so much about this one, but both of these are examples of in situ, or a type 2 hypersensitivity. But this is the one that's a little bit more prevalent and more relevant to our conversation. But the bottom line is both of these in situs give you the same result. Over here, this is a type 3, this is the circulating kind. So now you see these clumps because they get lodged. So you've got sort of clumps here, clumps here, clumps here, versus the in situ, which is nice and linear. Does that make sense? We'll come back to that here in a second. So as the antibody-antigen complex finds its home, whether it's type 2 or type 3, it's going to stimulate complement. It's going to trigger neutrophils, monocytes to become macrophages, and platelets to show up. You're triggering inflammation at the level of the glomerular basement membrane. Okay? So you have a local glomerular inflammatory event that's chronic. You get degranulation that takes place, right? You get long-term release of growth factors and cytokines, and so eventually you deposit scar or fibrin at the basement membrane of the glomerulus. That's the end phase of glomerular nephritis as an inflammatory instigator. That scar tissue on the basement membrane, do you think that helps glomerular function or impedes it? It impedes it. Does it increase urine production or decrease urine production? It decreases it, oliguria. Okay? That's glomerular nephritis. Now, if I was to ask you to characterize glomerular nephritis, whether it's a type 2 or a type 3 hypersensitivity, or if I was to ask it of which one is an example of an antigen-antibody complex that's circulating versus one that is glomerular basement membrane in situ, the in situ is the type 2, the circulating is the type 3, and I showed you these two pictures, which one do you think would be which? Don't say anything out loud. Get your answer and then share it with your neighbor. Let's see. What do you guys think? Anyone want to go? Yes, sir.
This is kind of a guess, but I'm going to guess that the one on the right is the type 3 or the circulating one, because you can see, I'm assuming that the green contrast is actually that APAG deposition. So that seems like it's in the vasculature around as well, in more blood vessels, and it's circulating rather than just deposited in the activated area.
Okay, so if maybe I didn't give you enough information. So do you see this right here? This tracing. So that's an immunohistochemistry marker to the antibody, and it's staining everywhere the antibody is found. Okay. And this is the glomerular basement membrane for sure. Same thing over here. This is glomerular basement membrane, and the green label is a fluorescent label that's labeling all of the antibody. What do you guys notice about the staining pattern here? Is it, like, for example, right here? Is it continuous or is it more punctate versus like right here?
It's a lot more porous, which could allow
so this is actually more continuous, more consistent throughout the entire basement membrane. On the right side, this is indicative of in situ. So it's targeting an antibody against the basement membrane, for example. Because the basement membrane is the entire structure, you get a more smooth or continuous stain. Over here, you've got areas of wide open black space. You know, right here, there's a big gap. There's a big gap here. There's a big gap there. There's a bunch of gaps right in here. So areas that are more continuous, like right here, there's a bunch of AB complexes that all bound. But over here, less of them bound, so you only see a couple of little dots. Does that make sense? So on the left side, you would surmise that this stain is going to be the antibody-antigen complex that's circulating. And this one is against something in situ, like the glomerular basement membrane. Okay? So we've got linear on the right, and we have granular on the left. Make sense? Okay. Let's talk about a couple of different types of glomerulonephritis. This one's called rapidly progressing glomerulonephritis. Rapidly progressing. This one's also referred to as crescent glomerulonephritis because of its appearance. I'll talk about that in a second. But you get a rapid progression of loss of function. This is usually associated with systemic lupus erythematosus. It's a lot of times found to be, or learned to be, an autoantibody to collagen 4. And so you can see the normal glomerulus on the left. You see the diseased glomerulus on the right. And what I'd like you to be able to appreciate on the left is this large Bowman's space, this nice opening of Bowman's space. Here you can see that it's being encroached upon, and here it's completely absent. You have the infiltration of these purple dots, or these cells. And so you've got proliferating epithelial cells and rapidly progressing glomerulonephritis. And we've got a number of different inflammatory cells that have infiltrated, like neutrophils, into this tissue. Over here, you don't see any cells in this particular area. Here you see a whole collection of cells. And then you also get this crescent-looking glomerulonephritis as it scars. And so you can kind of appreciate this pink tissue right here as it crescents over, as we're losing functionality of each glomerulus. Rapidly progressing glomerulonephritis, usually a type 4 autoantibody. Acute diffuse, our second type of glomerulonephritis. Acute diffuse, and then we'll look at chronic glomerulonephritis. So acute diffuse, this unfortunately can affect very young patients. Post-strep infection, post-strep throat, oftentimes between the ages of 6 and 10 years of age. Onset is usually 1 to 4 weeks after the strep infection. It could be a staph infection, it could be pneumonia, it could be viral. But the idea is you've got an infectious agent, an antigen-antibody complex, that gets trapped into the glomerular basement membrane, a type 3 hypersensitivity, and it causes a local inflammatory event in that area. And because it's granular in appearance, it's the left picture, right? A type 3 hypersensitivity. So type 3 on the left, type 2 on the right. Acute diffuse, we've got this antigen-antibody complex that's trapped in the glomerular basement membrane. We start developing these big inflammatory events. And again, you can see all of the inflammatory infiltrate that's coming in. I can go back to the previous slide to show you the normal glomerulus architecture versus acute diffuse glomerulonephritis, where the glomerulus is missing the space and you've got a local infection that's happening here after, like a strep infection or a viral infection. Yeah?
So you're saying that the strep, so you have like a free strep antigen
Correct.
that got embedded there, so when that antibody comes in, forms
Yeah, so typically the strep antigen and the antibody are going to find each other in the blood, and then they're going to get trapped here. So it's a
Okay.
classic type 3.
Okay.
Yep. Now, if this goes unchecked, patient isn't treated, it can progress to chronic glomerular nephritis long term. Okay, this is the most frequent cause of renal failure, chronic renal failure. You've got several nephrons that are destroyed. You get tremendous scar formation or scar tissue that takes place. So we can kind of appreciate this picture on the left. It's a different color than what we've seen classically. This is a Mason's trichrome, a trichrome image. The blue color is staining the collagen. You can see a quote-unquote normal glomerulus here with the Bowman's capsule. All these blue tufts are completely fibrotic, scarred over glomeruli that lost the battle and come out on the other side of wound repair, but it's not wound resolution, right? It's wound repair because you've healed the tissue, quote unquote, but you've lost the function. You don't have a functional glomerulus anymore. In replacement of a functioning glomerulus, you have a scar, a fibrotic scar, in the kidney, instead of like on the skin surface. You can understand how there's no functionality of these glomeruli. If you took the gross appearance on the right of the kidney at explant, and you ran your hands over the surface, chronic glomerular nephritis, it would feel rough, like like an orange peel, almost like cobblestone in nature. Okay, all these bumps. What I'd like you to do for SI, because I need to catch up a little bit too, is I want you to do this exercise on your own. This is a great exercise for SI. You saw glomerular nephritis in a patient. What would be some of the things and symptoms that you would anticipate in the patient? Use some of the terms that we talked about. Walk through what you would anticipate. What would happen with urine, up or down? What would be in the urine? What would be absent from the urine? Okay? All right. So that's glomerular nephritis. We talked about diabetic neuropathy already, or nephropathy. But we need to cover nephrosclerosis, or scarring. So, nephrosclerosis is often seen in patients that wrestle with hypertension, chronic hypertension. And so now the blood pressure that's moving into the kidneys is high. And so the pressure head that the renal structure or architecture experiences at the level of the glomerulus is higher than normal. And so the biology is going to respond by thickening. Okay? You're going to see scarring of the tubules, and you're going to see the morphology change into a hyaline morphology, which is very similar to what we see in atherosclerosis, otherwise known as arteriosclerosis. We'll talk about that more next week. So you can see in these two pictures right here, with this nephrosclerosis, you can kind of appreciate that there's hyaline deposition and a thickening of the walls of the arteries. So these are two arterioles that are fusing in Bowman's capsule. And because the blood pressure is high, the thickness of the wall of the artery increases to be able to handle the pressure. Next to it right here is, this is a venule, but an artery would be about the same size as this venule. Okay? It would be more round in appearance. It would be about the same size and the same thickness, but it would be round instead of oblong. Okay? You see how these are more round, but the thickness of this wall is pathological. So clinically, what are they going to experience with this nephrosclerosis? They're going to see protein in their urine. They're going to typically have focal areas of ischemia of the kidneys. and their serum protein level will go down because they're going to be excreting a lot of the protein. They're not going to be operating as a appropriate filter.
What's serum protein?
Serum protein, serum is a component of the blood, the major component of the blood, and the serum has lots of proteins in it. The biggest one, or the main one, is albumin.
Also, you're talking about the proteins that are in circulation in the blood.
Correct. Yep. All right, so glomerular nephritis to renal failure. So let's talk about renal failure. So what's acute renal failure? Acute renal failure is a rapid and severe decline in function with oliguria, or decrease in urine production. We've got a severe reduction in glomerular filtration rate, and it usually occurs using 3 different mechanisms, or via 3 different mechanisms. You can have something that happens at location number 1. So here's this drawing that I was talking about that I think would be helpful for you to be thinking about as you're studying. Right, so we've got blood flow coming in. We could have pre-renal, where you could actually have shock, where the kidney itself loses blood flow due to a blockage or severe illness, or it could be due to like trauma. Okay, patient gets in an accident and the aorta is severed, or they're bleeding, and large amounts of blood loss is happening. There's even internal bleeding in the internal organs, but the amount of blood flow that goes to the kidneys goes down dramatically. That would be pre-renal. That's before you ever get there. That could lead to renal failure. Number 2, it could be parenchymal. Okay, the kidney itself. Parenchymal just refers to functional tissue within that organ. So parenchymal, like glomerulonephritis. Glomerulonephritis that we just came from, if it was chronic glomerulonephritis and it was left untreated, you could actually see and anticipate there would be direct damage to the kidney, right? And this could happen due to inflammation from glomerulonephritis, or it could happen from toxins or drugs or an infection, or it could be a reduced blood supply that came from number 1 and it works its way to number 2. And then the last way that renal failure can happen, and it's going to sound aggressive because most of us that have ever either experienced this or known someone that's experienced it, will talk about how painful it is, but this is post-renal. So this would be in area number 3. And this would be things that would obstruct urine flow, like an enlarged prostate, or kidney stones, bladder tumor, injury, or it could even be a urinary tract infection. Okay, you could put UTI down there as well. So, acute renal failure, infections. We're going to talk about pyelonephritis, that one that I told you could write down at the bottom. We're going to talk about that at the very end of the lecture. So hang on tight, we're going to talk about here momentarily. But the etiologic agents that can cause acute renal failure, right? Many of these are all going to lead to oliguria, or a reduced production of urine. So if we look at the flow chart, right? So here we've got reduced GFR at the bottom, or oliguria, a reduction in urine production, and the acute tubular necrosis up at the top. This is when the kidneys tubule themselves are starved of oxygen because of blood flow reduction. So as they're starved of oxygen via blood flow reduction, you know, the nephron is the last to get the oxygen in this particular structure, just the way it's designed. So they're the most prone to ischemic starvation. And the ischemias that take place can actually be either through a loss of blood flow that causes the ischemia, or it could be through a toxic contamination or toxins that overpower the kidney, renal toxins. So one example of a renal toxin that many of us don't ever experience, but it's a chemical, and it's a radiopaque dye, known as barium sulfate. Okay? And so if you ever have a procedure, a surgical procedure where they need to use x-ray and they inject a dye or a contrast agent into your blood, it's a kidney toxin. And so they're going to manage the amount of radiopaque dye that they inject into you because they want to avoid acute tubular necrosis. They want to not kill your kidneys. Okay, so many of you probably haven't had these procedures, but maybe dad or mom or grandma or grandpa have had these procedures, and they're watching the amount of contrast agent that they inject. Okay, so that's an example of a toxin that can cause acute tubular necrosis, kidney toxin. The critical events that take place, well, you've got injury to the tubule network in the kidneys. You've got reduction in blood flow that causes major problems, as we're going to see on this flow chart. So if we take a look at this flow chart, we've got ischemia at the top. You've got tubular cellular injury that happens here, and or you've got vessel problems that happen here. The vessel problems like vasoconstriction or dysfunction of an endothelium lead directly to a decrease in urine production. And then if you damage the tubule network where you're filtering this stuff, you have reversible pathway or you have an irreversible pathway. But if it's reversible, you might actually lose distal sodium. So you'll have some feedback mechanisms that could actually kick in, and they can actually feed back up to the top. But if they're left unchecked, then you reduce blood, the production of urine. If there's detachment that takes place of the tubule itself, then you've got obstructions that take place by these hard casts that show up. And so you increase your intratubular pressure, and that decreases glomerular filtration or decreases urine production. And then the irreversible signs, like necrosis and apoptosis that you're very, very familiar with at this point in the semester. And so if either of these take place, where you're starting to kill cells off unorganized wise, or in a more organized programmed cell death, then we have leaking of the tubular network. And the leaking of the tubular network prevents it from creating urine on the outflow. So, bottom line, at the level of tubules, they're very susceptible to blood flow reductions. They become ischemic very quickly. And if you have ischemia, then you have tissue damage. That tissue damage can either be blood flow or blood vessel damage, or it could be the tubular network. Both of those are going to impact GFR or lead to oliguria, decrease in urine production. Okay? The etiological agents that can cause acute renal failure, shock. We talked about shock. So a traumatic event where you get a rapid loss in blood flow, trauma, blood flow drops. A third of the blood flow that comes out of the heart or cardiac output goes to the kidneys right off the bat. So they're very susceptible to shock problems. That decreases urine production almost instantaneously in a traumatic event. So what is shock? Right? Reduced ability of the body to return to homeostasis, severe reduced delivery of blood to tissues, getting zapped when you stick your finger in a wall outlet, definitely C. Hyperperfusion of the lungs, you're looking at the grade on my last patho exam. That's not the case. The average was an 80% in this class, so you guys actually should be very proud of yourself. So the answer here is obviously letter B, right? Up here, B. All right, in the last few moments, I want to talk about UTIs, okay? The last category of infection that can work its way up and cause renal failure. So as we talk about UTIs, we talk about pyelonephritis, which is an ascending type of urinary tract infection. An ascending type of urinary tract infection where it reaches the pilum of the kidney, and so that's why we call it pyelonephritis. Well, we also have descending types of infections that are bloodborne. So we have ascending and we have descending. So if we look at the descending infections, We look at the descending infections. There could be something in the blood, like a staph infection or E. coli. And because the kidneys are very susceptible to filtering, a lot of these infections are going to target the kidneys right off the bat. They're actually somewhat susceptible to catching as a filter some of these infections. And so that's how a hematogenous infection, otherwise known as a descending infection, can take place. The ascending infections come retrograde. So they come up from the urethra into the bladder, up through the ureters, and then target the kidney specifically. And so these are urinary tract infections. It's pyelonephritis if it actually makes it all the way up to the kidney. And then the reflex nephropathy, there's this natural reflux that takes place within urine outflow after the sphincters close. There's a little bit of a reflux to bring fluid back retrograde slightly. So you already kind of have a slight vacuum. If there's anything in the urethra, it's going to be brought up as a contaminant. So what does it really look like? Okay, these bacterial caused inflammation events can target the renal pelvis, the functional tissue of the kidney itself, even the renal calyces, and some of the contributing factors. So females are much more susceptible to pyelonephritis, which is an aggressive form of a UTI, okay, because it's affecting the kidney itself. It's the end game of a urinary tract infection. Females are more at risk because of the shorter urethra, and in the region around the urethra, it can be more susceptible to bacterial contamination than in men. Some patients have a more aggressive VUR, or this reflex that I was talking about, and so they're more susceptible to developing UTIs. They get them on a more routine basis than other individuals. Urinary tract obstruction. If there's something blocking it, okay, there's a kidney stone. Something's blocking flow. It's harder to push out contaminants, and it's easier for bacterial infections to move their way up. Diabetic patients are at higher risks of developing these UTIs that can lead to pyelonephritis. And the reason for it is because of flow, right? A lot of diabetics that are managed have flow issues associated with the kidney tubules. And then any sort of congenital abnormality where there's a longer pathway, or it's got a larger diameter, so flow is actually reduced. Maybe there's more of a tortuous pathway, so it's harder to flush contaminants out. So the reflex nephropathy, which is our last slide, this is a form of chronic pyelonephritis. It's associated with urinary tract infections and this vesicoureteral reflex, or the VUR, and it can induce scarring of the kidneys. And as the kidneys scar, right, we get this damage, this chronic, that's long, that's debilitating, because now you've lost function of the kidneys. Questions over diabetes, mellitus, or the renal section of today? All right, so pause for a second. So next week, we've got to go through liver, and then we've got to go through cardiovascular. And you are responsible for respiratory, which I've mentioned before, online. Okay? So that's our plan for next week. You guys with me? Okay.